Hi everyone, I'm Aditi Bhatt and I am currently responsible for all the social media educational activities for the SOGI. For this podcast, it is a great pleasure to welcome Kurt Van Der Speeten and Shigeki Kusamura, who happen to be my peers, good friends, and big pillars of the SOGI. Shigeki Kusamura is a surgical oncologist at National Cancer Institute, Milan, and Kurt Van Der Speeten is a professor of pharmacology and professor of surgical oncology at Ziekenhuis Oost Limberg in Genk in Belgium. Shika and Kurt, thank you for joining us today. This podcast is on the 2022 SOGI Consensus on HIPEC regimens, the section on technologies, and both Kurt and Shika were the main authors of this section of the consensus. So my first question to both of you is, before you started out with this consensus, what, according to you, was the ideal HIPEC regimen? And is there anything such as ideal HIPEC?
Well, thank you, Aditi. Thank you for having us and taking for this beautiful initiative. That's like a very big question. What the ideal HIPEC is? It's basically the reason why we did this consensus to a certain extent. But there is like some basic criteria to which a ideal HIPEC should accommodate. I think it should be standardized within your own institute and preferably within the wider scientific community. What we are trying to do with this consensus. So it should be standardized, it should be reproducible, and it should stick to the primary aim of what we are doing with intraperitoneal chemotherapies is trying to intensify the dose intensification. So anything in the technique that adds to improving that dose intensification should be part of an ideal HIPEC. And finally, I think it's important that it should be affordable. If we want this technology to have like a widespread impact on our patients, it should be both available in developed and developing countries to impact our patients' potential. So that for me is like a general overview of what an ideal HIPEC would be.
Okay.
Yes, thank you for having me on board. This is a very interesting initiative and hope to make a contribution. This is a very difficult question, I think. Kurt, you said about dose intensification, but you can increase the complications if you increase the amount of chemotherapy inside the abdomen, jeopardize the healing process of the tissues after surgical trauma. So the problem is, what is the surrogate marker to say that the HIPEC is going to work well or not? In 90s, you used to say that it was the pharmacokinetic advantage the amount of chemotherapy that you can get inside the peritoneal cavity as compared to what you can have inside the systemic circulation. Then we changed this paradigm, and you started talking about what we can reach as a concentration inside the tumor nodule. And all the things started working in this sense toward this objective. And then there is a third leap in which we started studying the microenvironment, and the disease that we are treating should be understood well to see whether the HIPEC will work or not. So the problem of defining what is the optimal or ideal HIPEC is all about finding the right surrogate marker that the treatment will work. So we are moving towards this precision medicine now, and I think we're going to get the answer as the translational research will develop in this area.
Well, I totally agree, and this is where we are standing, just in this kind of no man's land between awaiting results from both translational and clinical trials, and our experience with all the limitations we'd had, toxicities and things from the past. So we're in a little bit in the no man's land in between, where it's important that we once again we standardize and build clinical and translational research on a certain standard where we start with. It's going to be evolving enormously over time, but we need some starting points that we share.
I agree. Yeah.
So, why did you plan this consensus? What was the thought behind it? If I think of an ideal regimen, what I want to hear is it should be for 60 minutes or 90 minutes. This is the ideal drug for this particular disease or this particular situation, and this is the dose, and this is the target temperature. So, I mean, what was the thought behind the consensus? We all know that the evidence is quite limited. There are few studies comparing one regimen to the other. So, what did you aim to achieve with the PSOGI consensus? And could you give us some background about it?
I think it started in the aftermath, of course, of Pradesh 7, which was like a wake-up call to all of us that first of all we should actively think about any regimen we use instead of doing this on very limited data. Secondly, there was a huge realization that basically there was as many HIPEC regimens and technologies as there were centers. So we were really realizing that what one person was calling a HIPEC and CRS, and then this, of course, today about a HIPEC, that one HIPEC is not the same in one center versus the other one. And I think it's a critique we quite often get from other oncologists, medical oncologists, and translational oncologists. And I think it's right what they say. So it's non-standardized. The regimens, everybody has his own like adaptation of a regimen he has read up about, and the literature is quite limited. So it was time to bring it all together to present an expert panel throughout the world with the available literature and guidance according to it, and try to converge instead of further diverging on regimens.
Okay.
Yeah, this consensus is not the end of the process. This is the starting process. You know, you had to start from somewhere. And one of the points that we face whenever we design a clinical trial is to understand what is the standard. And having defined what is the standard, we can compare with different things, and that will make it easier to design clinical trials.
Okay. And would you say you were successful in the whole exercise with with the technologies, with just one quick word on that? 4 years down the line.
If you want it in one quick word, I would say that like any consensus, a good consensus, you're moderately unhappy with. meaning that you agree with a lot of the points which are made there, and you're willing to accommodate your current practice to it, and you're moderately unhappy with some of the results of the consensus. So there will still be some variation, but as long as we converge, I think we're making progress, yes.
Okay.
Yeah, I agree.
Yeah. Okay, the challenge I think would be for all of us to follow the results. If people do not follow the results, I guess we are back to where we started. So one of the surprises in this section was the question on closed HIPEC, with the majority of the panel saying that they preferred closed HIPEC to open HIPEC, or it should be preferred because compared to the open system, considering data on heat dissipation, operating room safety, and post-operative morbidity, there was a weak positive recommendation favoring the closed method. This is the result of the consensus. However, in this particular question, we do not speak in favor of the open method. And so what I would like to ask you is, is this just, this question, does it just bring out the advantages of the closed method over the open method, or are you recommending adopting the closed method in preference to the open method?
Maybe you want to take that one first, Shiga?
Yeah, I think the reason for this decision was influenced by the Americans, the American Society of Peritoneal Surface Malignancies. They established that the closed system was the most advisable, not because it is related to a better outcome, but it is related to a safer situation when we think about legal issues for the personnel in the operating room being exposed to chemotherapies and so on. And then a big part of the panel that voted in this consensus were Americans. I think this influenced a lot in the final decision. In effect, there is no evidence saying that closed is better than open. And after this is a conditional recommendation. We can leave each surgeon to take his decision. And if you consider, for example, Sugar Baker, who is the opinion leader, he uses collision technique, the open system, despite two consensus saying that the closest are the most advisable.
I totally agree with that, this is hugely influenced by the geography of the experts. I think we shouldn't lose focus here, in the sense that, as you say, Aditi, it clearly brought out the potential advantages and disadvantages of both technologies. And for instance, in my center, I practice both. If I have a patient with like a very constrained abdomen due to previous surgery with loss of elasticity of the abdominal wall, then I will use another technique than a patient which has a wide open abdomen. So it's not so much that should you always do open or always do closed. You should at least, and this is what we try to get at, realize that there is potential advantages in certain situations to one of these technologies. And for instance, Paul Sugarbaker himself, who, as you say, is using Colosseum technique all the time. He himself, if he uses Melphalan, which is like a salvage drug he uses sometimes, he converts to a closed technique, because this is a drug which has a high potential for toxicity for the operating personnel. So once again, that is a good thing to do.
So the general teaching is that stick to one method, because all your staff, all your assistants and technicians are accustomed to it. So perhaps this switching from one technique to other is good for a center like yours that is a lot of expertise. But for I think, sorry.
No, I totally agree there that stick to your own technique. We did this like anecdotal kind of thing in our hospital where we looked at the number of spillage sets we have used. So our let's say that our standard technique, our default technique is open at this point in time. And we looked at the number of spillage sets we have used over 20 years of practice. And all of them, except for one, were used in the first 10 years, meaning at a time where you're still building your own standard, your personnel is accustomed to it. This is where with any technique you might have problems. And once again, an open technique, if this is your standard, you've been using it all the time, your personnel is happy with it, it's really safe.
Okay. So the next question is regarding the ideal temperature. And, 61.5% of the panel voted for 41 to 43 degrees Celsius, and another 42.5% chose 42 to 43 degrees Celsius. My question to you is what should we target? And we know that as the temperature increases, the toxicity increases. So what do you have to say about this range? Would you always target 42 in all your patients, or do you target 43 in all regions, or 41, or do you vary it according to patients? And how significant is this?
Go, Shiga.
Okay. So well, the concept that we had to keep in mind is that of thermal dosimetry. So the toxicity is not related to the level of temperature itself, but also to the time of exposure to hypothermia. So there is a point in which this curve of toxicity suffers an inflection, positive inflection. That might be something like 42, 43 degrees Celsius, in which each degree Celsius of temperature increase doubles the possibility of complications. From this point downwards, lower temperatures related to less toxicity, even though the time of exposure is longer. So I think the ideal way to calculate the duration of the surgery, considering just the thermal dosimetry, is to have a kind of a device or algorithm that establish what is the optimal duration based on what you can find as a thermal distribution in the beginning of HIPEC. And I might be wrong, but Yonemura has a device that calculates the duration of the HIPEC based on this. And his HIPEC does not have a fixed duration, varies according to several other parameters collected in the beginning of the perfusion. I think this might be the best thing the best approach for the problem.
Yeah, two additions to that. Indeed, we also were made aware this summer of the device that Professor Yonemura is using, and that of course is like one step ahead of what we are currently doing. So the question, of course, is what we do at this point. Two additions. One is like anecdotal. In the follow-up of the consensus, I asked some people, so what do you mean by temperature? And I was surprised to learn that a lot of them mean the inflow temperature at the machine of the probe, not the mean temperature throughout the abdomen. Now that's a huge difference.
Yeah.
So even after the standardization, like a lot of things, it's process evoking and question generating. So first we should agree that this is not the inflow temperature. It's the temperature throughout the abdomen, especially if we want to talk dosimetry. And we'll come back to that when we talk about temperature probes and things like that. Second thing is that more generalistic, some drugs, if we want some thermal enhancement, they have a kind of cutoff temperature below which one there is basically no thermal enhancement, and we shouldn't use it at that point in time at an augmented temperature. So that's another addition.
Okay. But I think less than 41. Currently, you would not recommend that the target intra-abdominal temperature should be less than 41 degrees Celsius. Otherwise, it is not HIPEC. Do you agree with that?
Depends on the drug, because like you said, Kurt, you have several patterns of thermal enhancement. So the cisplatin, every degree Celsius that you increase, you're gonna have some cytotoxicity enhancement. And mitomycin C and doxorubicin had to surpass 42, 42 and a half. Otherwise, you don't have this temperature potentiation of the cytotoxicity. So even the OVPEC trial used 40 to 41 degrees Celsius. You cannot say that there was no thermal enhancement because they were using cisplatin. There is a drug that can accommodate for a larger spectrum of hypothermia and get the potentiation anyway.
Okay, so that is also my next question because you know, in the OVPEC 1, their temperature was 40 degrees Celsius. And now when people actually use the OVPEC regimen in practice, the temperature range is between 41 and 43. All the centers that are already performing HIPEC. So how does it impact the toxicity and the outcomes? We do not have any reports of toxicity. We do not have any, you know, any reports correlating this high dose of cisplatin and the high temperature with the toxicity. So what do you recommend? You know, in clinical practice, should we go to 40, those who are already performing HIPEC at 41 to 43, or is it okay to do that with this high dose of cisplatin?
One of the things is that, especially in the ovarian population and cisplatin, that of course the toxicity is multivariable. So it's not only based on the regimen itself, it's based on the patient background, nephrotoxicity before, because of systemic chemotherapy. So there's so many things to be taken into account that I think the wisest thing at this point is stick to the protocol, because at least for the protocol, we have data. And not to, of course, there will be those adaptations for certain patients, but not to wander too much away from the protocol for which we at least have limited data.
Okay. All right. So the next question is also related to temperature probes, and the panel voted in favor of having at least 3 temperature probes. As such, I think it would be difficult to prove that more stringent intra-abdominal temperature monitoring leads to better outcomes, but there are some things which we just have to take as such. And my question is, where should these probes be placed?
Basically, we use the temperature probes as a kind of confounder for a homogeneous distribution of both the heat and the chemotherapy solution. In that sense, they should be placed, let's say, as far away from the intake as possible in different quadrants or sectors of the abdomen to get a good representation of kind of mean and local distribution of the chemotherapy and the heat. And once again, it's a typical thing on which you will only find a standardization in a consensus. There's never going to be any trial that's going to give us an answer there. So we agree on that based that, okay, if we do that and we get a homogeneous temperature distribution in 3 probes throughout the abdomen, that probably is going to represent a quite homogeneous chemotherapy and heat distribution.
So in your practice, how do you do it?
I have one of the things that for me is important is have a asymmetrical kind of intake and outtake flows. So I have 1 intake and 3 outflow probes to avoid shortcuts between an inflow and outflow probe. And I always place my temperature probes at the outflows. So both 1 lower abdomen, 1 right subphrenic, 1 left subphrenic. This is my practice.
Okay, and Shika?
Yes, I use 2 probes inside the abdomen besides the inflow and outflow. And I think the more probes you use inside the abdomen is better to capture whether there is a heterogeneity and the distribution of the temperature. And you have a preclinical model in rats where this group of researchers from Netherlands defined the optimal number of temperature probes and cannulas, inflow and outflow. And then I think in humans, nobody has tested it.
Okay. So 3 probes and place them as far away from the inflow catheters as possible. And the next is perhaps the most controversial issue about drains, but I think the panel is quite old-fashioned. 52% recommended the routine use of intra-abdominal drains, and another 31% said that they could be used. Even in the ERAS guidelines, more than 50%, just over 50%, favored the use of drains. So the question is, when would you not use a drain in a patient undergoing cytoreductive surgery? In your practice, is there ever such a situation where you would not drain the abdomen?
I use them in all my cases. It's still a little bit of an enigma to me, this obsession with trying to get rid of drains. And this might have some unhappy results in the end. There was this week a publication on pancreatic cancer where there was the same kind of evolution, that the shorter drains and JAMA surgery this week. She clearly had a good publication that omitting drains had, in the end, standardized emitting drains has a negative effect on morbidity in these patients. More percutaneous drainages, more abscesses that needed to be drained. So we should be very careful with this, what I call obsession with omitting drains.
Yeah.
Yeah, because the thing to omit the drains comes from colorectal cancer cases, the conventional surgery in colorectal cancer. And it's totally different from peritonectomy procedures. Maybe if you do a district peritoneal resection in patients with a low PCI, you can omit the drains, but usually I do like you do I put always the drains, but sometimes if the surgery is limited, maybe you can omit the drains, but most of the case in our center, we operate cases with a PCI of more than 20. So it's a total different situation from conventional colorectal cancer surgery. So we have to put the drains.
Okay, I agree. It's safer to put it and remove it as early as possible than not do it and deal with fluid collections and abscesses. So there were a lot of questions in the consensus on safety considerations, and the consensus was achieved on 10 out of 16 of these questions. Some of the practices on which a consensus was not reached seem to not be the ones that a lot of us would be using, like changing gloves every 30 minutes, using smoke evacuators to suck the chemotherapy fumes, or placing absorbent towels on the floor. So what are your comments on these measures on which no consensus was reached? And should any of these be used in clinical practice?
I think two thoughts. First of all, one of the thinking behind posing these questions to the expert panel was that the results of the consensus are going to be used by starting centers. So it's important, I think, at this point in time, that we give them some guidance, something that they can take back to their institution, saying that, well, this is what a good HIPEC as to technical measures should look like. So not a lot of them are basically the evidence is extremely limited, if there is any. Second thing is that one surprise to me in the one we didn't get a consensus on was the smoke evacuator. For me, there is like quite compelling data, both from CRS HIPEC and other kind of extensive surgery, that this is like a very nasty thing inside the operating room. Up to the fact that, for instance, in the Netherlands, you cannot open an operating room without a smoke evacuator. So that was like a surprise to me. It's the point where we get to the place where I'm moderately unhappy with results.
I think because it was specific for HIPEC, and the people who use closed HIPEC probably thought it was not necessary. Yeah. So, all right.
Yeah, this is a safety is a topic where the evidence is even lower as compared to other topics of this consensus. So that's why you have this heterogeneity on way of handling this issue, and it was quite expected that no conversions will have happened. So this is the result. Take it or not.
So I think the message to the audience should be that follow as many of the safety recommendations as you can. I think there is no compromising on that. Yeah.
Agree.
Yeah. So then we move on to the questions regarding the initial individual drugs. And for mitomycin C, there is a wide range of doses, and ranging from 10 milligram per meter square to 35 milligram per meter square. And in this, at least we know that higher doses are associated with higher rate of complications if all other factors are accounted for. So what do you recommend in a patient who is at a high risk of complications? Let's say you are using the 35 milligram per meter square dose. So do you do a 25 or 30% dose reduction, or you just use a regimen that has a lower dose, like 10 milligram per meter square, or combining mitomycin C with doxorubicin?
In our practice, we are actually using a 20% dose reduction in our high-risk patients. But once again, this is a little bit of an extrapolation from what we know from systemic chemotherapy trials. It's not based on any data. I think the high dose versus low dose thing is like a very important thing, and we reached some consensus. But once again, it's not the end. It's just a starting point. Just to illustrate that there is currently in the UK starting a randomized trial comparing the Basingstoke regimen versus the high dose 35 milligrams per square meter Dutch regimen. So it's just like a starting point, and we're going to get very interesting data from that, both on the efficacy and, as you say, of great concern to us of the toxicity of the regimens.
Yeah, the mitomycin C is very toxic, and the only study that we found during the literature review in this consensus reported on just a few patients, less than 40, and they said that if the total dosage of mitomycin C is more than 30 milligrams, you can have an 8 times higher risk of complications. But this is a tiny study, a retrospective study, and we don't know actually what is the correlation between dose of mitomycin C and the side effects. And this is a study in Basingstoke, I think will clear several things, because the Basingstoke dosage of 10 milligram per square meter is something that was not considered in the study comparing several chemotherapy regimens in PMP using the PSOGI database. So we don't have much data about how this low dosage mitomycin C regimen works in terms of side effects. And it's a non-inferiority trial. I wonder how many patients they will have to recruit. It's going to be a huge trial. And they are not relying on other centers. They're doing a single center randomized study.
So if there is a patient who has extensive disease, you are more worried about complications in that patient because of the cytoreductive surgery itself. So personally, my tendency would be to use a safer regimen, a regimen that is known to be less toxic in such a patient. And having said that, you talked about dose reduction. What about reducing the temperature or duration of HIPEC to avoid toxicity? We put these questions up for vote in the ovarian section, and the panel voted for first reducing the dose of the drug, then the duration, and then the temperature in that order. So what is, do you advocate doing that? There are some surgeons like Vandriel, she says if you're doing the HIPEC, do not make any modification irrespective of the patient profile. If you uh, do it without modifications. But there are others who, at least I'm one of them, who would reduce the time from 90 to 60 minutes or keep the temperature on a lower side, do a dose reduction. What do you recommend?
In my practice, I stick more to the Van Driel's ideas, stick to the regimen as much as you can. If I do a dose reduction, it's not so much based on the extent of the surgery, it's more on the pre-existing condition and especially exposure to systemic chemotherapy before in my patient. If the bone marrow potential already has been compromised, then I would do a dose reduction. But the extent of the surgery is very seldom a reason. If I do it, then it's indeed a dose reduction. Although, if you look theoretically from it, if you would decrease the exposure time, especially for platinum derivatives, we know it from oxaliplatin, that might be a very important way of reducing the toxic potential.
Okay.
Yeah, the problem of reducing the temperature in specifics of mitomycin C is the fact that is the possibility to lower the dose, and you don't have any thermal enhancement of cytotoxicity. For cisplatin, you can do it theoretically, but for other drugs like doxorubicin, mitomycin C, I will be a little bit concerned. And yes, we do the dose reduction, 20%, 25%, depends on the condition of the patient. Not because the patient receives a systemic chemo, because this is not the most important risk factor for complications. As complications in CRS is much more related to how much disease you are taking out, how much viscera you are removing from the patient. The magnitude of the surgical trauma is much more related to complication rather than the treatments that the patient received before. Exception for bevacizumab, this is an exception, but usually systemic chemo is not necessarily related to side effects. And the problem of chemotherapy inside the abdomen is not the systemic toxicity. The systemic toxicity occurs in 5%, less than 5% of the cases. It's related to enhancing the surgical complications. If you do a suture in the bowel, chances of anastomotic leak doubles if you use HIPEC. So this is the main concern of putting chemotherapy inside the abdomen. Mm-hmm. Not because the patient will develop neutropenia, anemia, and so on. This is very rare side effects.
Okay. All right. So one of the important things in reducing the systemic toxicity, one of the important drugs has been sodium thiosulfate. So I would like both of you to, tell us more about sodium thiosulfate. We know its advantages, but what about the disadvantages? And which patients should we use sodium thiosulfate for?
Okay, so my initial thoughts on this, let me start with an anecdotal thing. When Wilhelmine sent me the proposal for the OV-HIPEC-1 trial, I was greatly concerned about the addition of thiosulfate at that dose, because basically it was an extrapolation from systemic chemotherapy where thiosulfate has been used as a renoprotective agent since the 80s. But that we have to understand. First, we have to understand why cisplatin is nephrotoxic, or the platinum derivatives in general, cisplatin, of course, the most. It's because, first of all, there is accumulation of the cisplatin in the renal cells and the extrarenal matrix. And it's both inflammatory pathways, it's apoptotic pathways, and oxidative pathways that are involved. And so basically the thiosulfate as a hydrogen sulfur provider, does the opposite. It is anti-apoptotic, anti-inflammatory, and antioxidative. But that is like a very, it's walking the line between toxicity and decreasing the effect of our drug. So my main concern when Wilhelmine sent me the proposal was that basically, and if any thiosulfate would end up in the peritoneal cavity, that it would annihilate the effect. I've been proven wrong, greatly wrong by the trial, but it was a concern. So thiosulfate has a very good renal protective profile, but it comes with some at least theoretical potential decreases in efficacy.
Yeah. So we are going to study this issue, and we are testing on organoids. What is the minimum quantity of thiosulfate necessary to counteract the cisplatin cytotoxicity? There's going to be a project that we are asking for funds, and we are going to analyze also the pharmacokinetics of thiosulfate. You are given in the vein, and we don't know how much is arriving in the peritoneal cavity or inside the tumor nodule. So this is another thing that we are going to study, and we are evaluating if it's the case to randomize between thiosulfate and other nephroprotectors like mifostine, and doing just hyperhydration in the preoperative period.
I think what you're doing there is like a perfect example what we're trying to reach with this consensus. We start with a consensus. We choose a regimen, let's say the HIPEC 1 regimen. We see some potential limitations, potential disadvantages. It's hypothesis and question generating. We address it again in first translational and then clinical trials. And I'm sure that in 5-8 years' time, we're going to have a far better answer and a far better regimen.
So this was not the answer, at least I was expecting. I was expecting some recommendations that for 75 milligrams per meter square cisplatin, use sodium thiosulfate. For 100 milligrams, use it. For 50 milligrams, whether you use it or not. But we have some interesting studies in which they have shown, even in the HIPEC 1 trial, that for a dose of 75 milligrams per meter square, when you use sodium thiosulfate, your renal toxicity is almost nil. So I think both of you would still recommend its use till we have the results of these studies that look at the concentrations in the peritoneal cavity.
I'm going to bounce back the answer you gave before, Aditi. Stick as much as you can to the consensus we've made at this point in time, and at least we have data for that. Is it perfect? Yeah, no, absolutely not. But
because,
I stick to it.
It is, we have for years not been able to use the HIPEC 1 regimen because sodium thiosulfate was not available in India, and in the last few months it's become available. So, and then so it's where we would not use, you would also not recommend using 100 milligrams per meter square without sodium thiosulfate.
Absolutely. Yeah. I understand when they proposed the trial, I understood the rationale, especially with this high dose of using it, but I was concerned about the efficacy intraperitoneally, but proven wrong, as said before.
Okay, all right. So the next is the dosing of the drugs. And, another surprise for me was that the body surface area-based dosing was voted over the concentration-based dosing. We have the COBOX trial, which showed that the concentration-based dosing was superior. So what are your thoughts on this, and what do you recommend?
Yeah, of course. You go.
Go ahead.
No, well, first of all, as the author of the COBOX trial and as a pharmacologist, the driving force, of course, for efficacy is concentration. So for me, it's still an enigma that both in systemic chemotherapy and in IP chemotherapy, BSA it's like an anachronism. that we use it because it's a very bad representative of systemic volume. So, but it's what you see a lot of people stick to it. That being said, if you ask a lot of experts are using BSA based or concentration based, they tell us that they calculate based on BSA the dose, but at the same time, the amount of carrier solution. Now, that for a pharmacologist is concentration based because you end up with a fixed concentration. So a lot of people who think that they do BSA based are actually doing concentration based.
Because the fluid is based on the body surface area too.
Correct. If you calculate both the dose and the volume on the BSA, you're basically using concentration based.
Okay. And Shiga, what I think we can't hear.
Yeah.
Yeah.
You have two fractions, and you divide one fraction to the other, and the denominators will be cancelled mutually. So it's concentration based at the end.
Okay. So I'm not going to talk about stat dosing because though some surgeons follow it, I think at present, they are, it should be limited to certain centers of expertise, and we cannot at this point recommend stat dosing.
Agree. This shouldn't be, at this point in time, shouldn't be what we send out as a message to the general scientific community.
Okay. So now I have some pragmatic questions. We have in ovarian cancer several positive trials, I would say. The OVPEC 1 with 100 milligrams per meter square of cisplatin, the COVIPEC 1, at least the interval subgroup had a huge benefit in survival with 75 milligrams per meter square of cisplatin at a higher temperature. And then we have SHIPOR, in which the same dose was used, 75 milligrams per meter square for 90 minutes at a higher temperature than OVPEC. So what are your recommendations? I know we have the ovarian section separately, but when we conducted that consensus, the results of the trials for recurrent ovarian cancer were not available. So stick to the regimen that has shown benefit in the trial, or use a regimen that showed a benefit for all the indications. And would you consider comparing two regimens in ovarian cancer? Would you consider having a trial in which you compare the OVPEC with the Shibastin regimen or a cis-doxo regimen?
Yeah, I think we should stick to the recommendations, like we said before, and we have to follow the Vander's regimen. If the SHIPOR trial was published after this consensus, this is a time to revise the consensus, but until it is not revised, we should stick to the consensus. And regarding the question, it's worthwhile to compare 75 versus 100 milligrams cisplatin. I think it's theoretically, yes, but this is not feasible. You're going to work with a very narrow difference in terms of complications and outcomes. So we're going to need a huge number of patients. So randomize them is not worthwhile. One thing that we can do is to measure the complications, the safety in a big prospective registry, and see what happens in the real life. And this is not a year, but this is what is possible to be done.
I totally agree. That was, first of all, that was a nice trick question, of course, Aditi. But we stick to the recommendations. You're not going to get us away from that. And I totally agree that consensus for some of the questions we ask is never going to be a comparative or a randomized trial that's going to give us an answer. The number of patients involved in such trials is just beyond the grip of anything we can do, both in number of patients available and logistics. So I think we are definitely, yeah.
And would you consider comparing cisplatin with cisplatin and doxorubicin based regimens? I mean, what I'm trying to get at is, if you see the margin of benefit in some of these trials, it is quite limited. So is it possible to increase this benefit with a different regimen or a different kind of HIPEC, let's say a triple HIPEC? Now, this is again a pragmatic question, like, I'm asking you to look into the future. If you were
Yeah,
to look at recurrent ovarian cancer
yeah.
or primary cytoreduction with HIPEC, would you consider a trial that compares two regimens?
I would consider any trial that is multi-drug. So that's definitely the next step. But as you say, it's glimpsing into the future. But if we know anything from systemic chemotherapy, as I've said so many times before, it's multi-cycle, multi-drug, and it has a cell cycle specific drug. So any step towards that kind of ideal, I'm willing to consider in a trial setting with a good toxicity monitoring. So yes.
Yes, I agree as well.
So,
Um,
would
yes, go on.
there are these trials where you have a superiority design where you can get away with a limited number of patients. So would you want a large trial or some kind of rapid trial, so to say, where you have about 120 patients you can easily recruit in a year or two?
Aditi,
Yes,
the words rapid and trial don't go in one sentence.
yeah. There are ways to uh, save some resources, instead of going straight to a classic phase 3 trial, you can do a phase 2 randomized, and you can increase the alpha or type 1 error from 0.05 to 0.1 and decrease the power. Instead of 80%, 90%, you can reduce down to 0.7. That's a temporary trial. You can go forward for a more classic randomization using lower type 1 error and higher power.
I totally agree that we shouldn't make the mistake that has been made in some systemic chemotherapy trials. When we look at the alpha, we're looking at a clinically significant difference and not a statistically significant difference. So indeed, these kind of creative designs can be very helpful.
Okay. All right. Coming to the drug combinations, one of the surprising findings in the PSOGI study published in JAMA on PMP was that the best survival was with mitomycin C and cisplatin. And though it is not a good combination theoretically, experimental data shows that it has a synergistic effect. Now, following this publication, there has been a reflex response of switching over to this regimen, not just for PMP, but for colorectal cancer as well. So what are your thoughts on this? For PMP, we have the consensus. Of course, we have the results of the consensus on PMP and colorectal cancer both, but what are your thoughts on this switch to mitomycin C and cisplatin? And are they, we always consider when we compare the mitomycin C-based regimens to the oxaliplatin regimens, it's like it's the safer regimen. So is this really true with this? The dose in this regimen is not very low, the combined dose of mitomycin C and cisplatin. So what are your thoughts on switching over to this regimen?
The combination of cisplatin and mitomycin C, we used to use 40 milligrams per liters of perfused of cisplatin and 50 milligram of mitomycin C per square meter. And we always reduce the dose of these cases. We have been reducing it. And what we have noticed is that it's close to what we established as the standard in this consensus. So 75 milligrams of cisplatin per square meter plus mitomycin C, I can't remember exactly, but the dosage after several dose reductions was similar to what we established as a consensus. And yeah, the combination of cisplatin mitomycin C is justified not because we are putting together two drugs with their own cytotoxicity, creating a kind of synergism, but you have some experimental models and saying that you combine both because mitomycin C enhances the accumulation of cisplatin inside the tumor, inside the tumor cell. So it's not because we are taking advantage of additional cytotoxicity from mitomycin C. This is a similar mechanism that we can find in combining oxaliplatin plus 5-FU. 5-FU is much more related to increasing the bioavailability of oxaliplatin inside the tumor cells instead of producing an active cytotoxic effect on the tumor cells.
Okay. So, Kurt, do you have any comments on that? No?
No, I agree that what we basically changed our practice for PMP based on the consensus. And for colorectal, we're still using the Dutch high dose regimen. I think it's the data we have at this point in time. I totally share the let's say translational comments that Shiga just made about what mitomycin does to the cisplatin, and same for 5-FU and oxaliplatin. So it's important to realize that we're not looking at the wrong kind of situation. Yeah, sure.
Okay. So the other switch was, of course, after the PRODIGE 7, and even the results of the consensus on colorectal cancer. There was huge agreement that mitomycin C should be preferred. If you look at the results of the PRODIGE 7, they are subgroups, but patients who had surgery up front and patients who had a PCI of 11 to 15 benefited from HIPEC, and this was the high-dose oxaliplatin HIPEC. How do we, it's just the clinical data doesn't favor one drug over the other, though we have a lot of preclinical data from organoids that shows that mitomycin C is the more effective regimen. How do you put this into perspective? Like, should oxaliplatin be used, or is it okay just to use mitomycin C for these indications, though in the trial oxaliplatin was used? Because when we use, sometimes we have to justify, if we have to show evidence to the patients or the medical oncologists, we would go these subgroups, but then we are just switching one regimen for the other based on preclinical data and the results of a consensus.
Well, I definitely at this point in time wouldn't go to oxaliplatin in the 11 to 15 PCI group. The study was not powered for this. It's one of the reasons why they needed so much time. They tried to push this message when they were publishing, and it took them a lot of time to get the article out. Basically, one of the reasons was here that the study is not powered to make that kind of conclusion, and we shouldn't do it. And it comes in line with some of our translational work that basically oxaliplatin at 30 minutes doesn't give apoptosis. The cells are not dying. So I think the future of oxaliplatin, for which there is absolutely a future, is going to be in a longer duration, lower dose. And as long as we don't have conclusive data on that, I would steer away from that, from the Elias regimen.
Okay.
Yeah, I think there was a kind of overreaction after PRODIGE 7. Everybody started blaming oxaliplatin as the key factor that was responsible for the trial failing to give a positive result. Oxaliplatin is not a ditch to be. I don't think it's like you say, it's not a bad drug. It's badly used. So we have to change the way we are given oxaliplatin instead of shifting completely to mitomycin C. This could be my personal view, but I don't think mitomycin C is going to save the day. If you look at the recent BGS paper, putting together the cohort of patients from the United States and the France, RENAP, ASPSM joint venture, they retrospectively analyzed the several regimens in colorectal cancer with peritoneal medicines, saw that oxaliplatin is not doing so badly like we saw in Project 7. It performed better than mitomycin C, so a median overall survival of 47 versus 39. So I think the match is not over. We have to still continue investigating oxaliplatin and try to find a better way to give it to the patients.
I totally agree. It's also in with recent translational research, for instance, from the Onno Kranenberg's lab in organoids, showing that, as you say, mitomycin is not going to save the day. So mitomycin as a solo drug is performing not too good in the organoids, and then it's definitely there's going to be a place for both mitomycin and oxaliplatin and a lot of other drugs, but it will be a better regimen. And one of the big good results, the best thing that happened with PRODEUCE-7 is that we actively started thinking about that we are devising new ways, first translation, of course, trying to improve both of these regimens because there is room of improvement for both of them.
But in this consensus, we were not able to define the parameters of the oxaliplatin HIPEC. The panel agreed to 200 milligrams per meter square. They agreed to the use of 5-FU leucovorin, but there was no consensus on the time. I think a third opted for 60 minutes, a third voted for 90 minutes, and surprisingly, few people voted for 2 hours, which is the duration in the Wake Forest regimen, and the same with the carrier solution. So there was no consensus on that. And I would like to have your comments on that.
Well, I think
yeah.
it's a perfect example of the aftermath of a negative trial, that people flee to all the ends of the room, and you will see a very wide kind of solutions they come up with. A lot of them not based on any translational or preclinical data. I think it's just the time frame where we did a consensus that I think it was correct to expect these kind of results. There's nothing wrong with that. Once again, it doesn't say that oxaliplatin is a bad drug. We just need more time to figure out how we should use it. And at this point in time, to answer, sorry, I'm interrupting you. At this point in time, I cannot, in the clinical setting, in the preclinical setting, we're starting now a phase 1 trial with high doses, but in the clinical setting, I cannot advocate oxaliplatin use, despite I'm being a big believer of oxaliplatin.
You asked about the carrier solution for oxaliplatin. Yeah?
Yeah.
Correct.
Okay. So people use it to say they had to use glucose, 5%. And there is a preclinical data saying that even if you use saline solutions for oxaliplatin, the amount of drug that is inactivated by saline solution is ridiculous, is a tiny amount of the drug. So you can use it with the with oxaliplatin saline solution. That would make it easier to handle the intraoperative complications regarding metabolic disturbance, hyperglycemia, and so on.
Okay. So as of now, there is no indication for the use of oxaliplatin in routine clinical practice. In this consensus, we've not had any any recommendation where oxaliplatin would be, any oxaliplatin regimen would be the regimen of choice. So for the moment, both of you recommend not using oxaliplatin HIPEC outside clinical trials.
Yes.
Correct.
Yeah. Okay. And let's see if the gastreship is positive. Because the
That would be
gastreship,
that would further confuse us.
yeah. So we want it to be positive, but with a bit of a hesitation. So the last part is, of course, on taxanes, and we know that taxanes have the best pharmacokinetic properties, but the thermal enhancement is questionable, and they are cell cycle specific. So perhaps just one single shot of 60 or 90 minute HIPEC is not the best way to use these drugs. And like oxaliplatin, we have no recommendation for paclitaxel-based HIPEC in the entire consensus. But there are some groups who still use paclitaxel either alone or in combination with cisplatin. A lot of Spanish people use it. So I want both of your thoughts on the use of paclitaxel HIPEC.
You want to go first, Shiga?
Yeah, like you said, Aditi, I have some concerns regarding paclitaxel. Can you hear me?
Yeah.
Yeah. First thing is the absence of thermal enhancement. So you're giving taxane with a high temperature, and you're not increasing the cytotoxicity of the drug. So this is no matter how high is the hyperthermia. And the second point is cell cycle specificity. So taxane is able to disrupt the mitosis because it acts on the microtubules. So it is a kind of obstacle to the polymerization of the microtubules. And then if you look at the ovarian cancer at a single time point, how much of the tumor has tumor cells in the mitotic phase. So it must be something that between 10 to 12%. So if you have designed the HIPEC to give just a single shot, if you are using just paclitaxel, it will destroy only 10% of the cells of the ovarian cancer. So I don't think there is enough rationale to defend paclitaxel as a drug for HIPEC.
Totally agree that it just what the results are reflecting is the understanding that this as a single shot is not going to work. That being said, taxanes are hugely good molecules. So the future is going to be either in sequential IP chemotherapy, but we know what has happened with the results from the Armstrong trial, the Ozos trial. So the normothermic sequential trials, unfortunately, they have never been implemented. The second thing is that another potential future is like what the Wim Salen's lab is doing with taxane nanoparticles, where you basically extend the exposure of the tumor cells to get more cells in the mitotic phase. But these starting now going into clinical trials. So it's been going to be interesting to see what happens there.
Okay. So oxaliplatin, no oxaliplatin, HIPEC in clinical practice, no paclitaxel, HIPEC in clinical practice. Those messages are quite clear. And the last question is unrelated to the consensus, but since both of you are here, I have to ask it. What are your thoughts on the Chinese triple HIPEC? You know, that's done on day 1, day 3, and day 5. And would you consider doing some clinical or preclinical studies with this kind of a HIPEC? It is not done in the OR, it is done in the ward.
Okay, two thoughts. On one end, it perfectly accommodates to the thinking that we should have multiple multiple drug exposure. So yes, the future is going to be out there. I'm a little bit worried about the other end, which is that I haven't seen enough preclinical data, maybe because we're not exposed to them in Chinese literature. But I haven't seen enough preclinical data to, at least in my eyes, be able to do a clinical trial at this point in time with a regimen where I have little evidence for. So, but the basic thinking is very sound. Yes, multi-cycle, multi-drug.
Yeah, there is the theoretical thing that is sound, but if I had to do HIPEC repeatedly, I would do not without the distance of a few days between one and the other. I would wait for the tumor cells to restart growing. So we had to do it at a distance of 2 weeks, 3 weeks, and so on. But it's, the problem is the feasibility. I don't know whenever they reopen the patient to do a HIPEC, how much adhesions they find, and what is the tolerance of the tissue to submit to them to so much thermal trauma and chemotherapy trauma, surgical trauma, and so on. So we need more data to say whether this is acceptable or not.
The patient is not taken to the OR. It is done through the drains in the ward.
Yeah.
Or in an isolated setting. So I guess that is...
In that case, we have some concerns regarding the diffusion of the drug. So you're given intraperitoneally, but how to handle the problem of the adhesions.
Okay. So we'll see if we'll wait for some of you to at least take that up, and it would be really interesting. So any closing remarks, what message would you like to give to the audience after this huge manuscript, a lot of questions, a lot of issues, with a reasonable consensus on many contentious issues? What would be your take-home messages?
Yeah, this is a starting point. And obviously, it's impossible to test all the clinical scenarios if you multiply the variations in the parameters. You're going to have 1 million possibilities, different levels, temperatures, different drugs, different dosage, different ways of, different carrier solutions and so on. So I repeat always what Kurt Van Der Speeten, my colleague, he used to say, Project 7 was one of the best things that happened in peritoneal surface oncology, because forced us to go back to translational research, understand what is going on, understand the tumor biology, and to learn how to do research. And if you want to take advantage of translational research, this is a good moment in which you're going to test all the possibilities in animal models, preclinical models, and see whether there is an advantage, and then go to test in humans, phase 1 trial. So the translational phase of the research is the phase in which you are going to discard all the situations in which you are quite sure there is no advantage. So it's senseless to start thinking about randomizing every question. So we have to test first in preclinical models, see what is going to happen, and then jump to humans. So I think it's going to be a bright future for us.
Well, I couldn't agree more that I'm very happy with the consensus, in the sense that it did what it needed to do, bring us together, give us an interval starting point, but mostly the subsequent search we already see now in translational research, in proposal for trials, is building on this, and this is what, as Shiga rightfully says, it really is. If I envy the people who entered the field now, because these are going to be like very exciting times for them, both on the clinical and the preclinical front. And finally, we are coming a little bit in line with what happened in systemic oncology in the 80s and 90s. So yes.
So yeah, I think this has been a great discussion, and there are certain new things I learned today about the thermal dosing, about sodium thiosulfate in peritoneal fluid, and I think we have very clear messages from this consensus that we should stick to the recommendations to bring about some homogeneity in practice. So thanks a lot to both of you for this consensus, for the huge manuscript, and for this podcast. Thank you.
It's a pleasure.
was a pleasure. Yes.
Thank you.